right, can everyone hear me okay?
Yes.
Yes, I can hear you.
Great. Can you all see the PowerPoint all right?
No. No.
No, you can't. All right. So we'll keep working on that. All right. All right, can we see it now?
Yes.
Yes.
Okay, perfect. All right, well, welcome to October office hours. And thank you for joining us. We are recording the session as usual. And as always, if folks have anything along the way they'd like to talk about, questions, comments, feel free. We always have the chat function as well. And we'll get started. And look forward to having our discussion today. So we have policy and procedure updates, quality management and performance as usual. We have children's program updates and some training things that we're going to announce and other topics as well that we'll be presenting. So number of policy procedures this month and some upcoming policies as well. So we'll get into it. So Jessica, you ready to go?
Yes. Can you hear me?
Yes.
Okay, perfect. Yes, so today we'll be going over a number of policies that have been updated recently, and then upcoming policies for hopefully next month are going to be our disenrollment policy, and then health home serving children, HCBS rights and choice. And go to the next slide. So first we have access to services. There's no change to this policy. It was just an annual update. This is a policy that goes over that each CMA has the responsibility to ensure 24/7 access to the care manager, to a care manager. Each CMA will, I'll just mute everyone. Okay. Each CMA has the responsibility to ensure that, and then they can do that however works for their CMA. Some use a centralized on-call number. Some of you have an on-call person, so it's left up to everybody, but nothing new there. You can go to the next slide. Next, we have caseload ratios. This is actually quite a lengthy policy because we include all of the options for Health Home Plus in there, but there are no updates to that. And I didn't really want to walk through all of the things that you guys are obviously already privy to. So this was just an annual review. No updates to this policy. Just keeping in mind that we have our point system that we utilize to really make sure that everyone is keeping up with their caseload ratios, making sure that your supervisor to care management ratio is good. This way that supervisor can kind of ensure quality and oversight for all of those cases. And then we do have that hard and fast stop rule when it comes to serving Health Home Plus folks. You cannot be over 20 cases per one care manager or 60 points to one care manager and still bill Health Home Plus. But other than that, everything is recommended and it is monitored for quality if you do exceed those caseload limits. Any questions on that? Alrighty, we can move to the next slide. Next, we have continuity of care and reengagement, or also known as diligent search. This was an annual update. Also, at the same time, we did update the sections for AOT members. There were some modifications for those folks that serve AOT. If you serve the AOT population specifically, There were some added steps, but there's also an added benefit to following those added steps now. So if you do have a member who is AOT and they are missing and they are put into diligent search, that is considered to be a significant event, you want to make sure that you're reporting that to the LGU. You want to make sure that all of your efforts to make contact with that member, telephonic efforts, in-person efforts, they all need to be documented in your EHR. And you want to make sure that you're communicating that with the LGU or your point of contact for your AOT clients. You can go to the next slide. The one thing that has really changed is if you are doing the other process and you are not having those 4 in-person face-to-face visits, you would bill down at that lower rate code. Moving forward, if you have an AOT member and you follow the below procedure, you will be able to bill at the full AOT rate, even if you do not have those in-person face-to-face contacts. So if you have somebody who is missing, you notify the LGU, you do your significant report, you communicate with the care team, you are contacting anybody who has reasonable knowledge of that member's whereabouts. So maybe a family member, emergency contact, you're checking your HCSCN alerts, jails, file missing persons potentially, and that you were obviously attempting to make door knocks face-to-face. And you were following up weekly and doing not all of these things, but a good portion of them to do your due diligence to find that missing AOT member, you will be able to bill at the AOT rate, that full rate. So you no longer will get knocked down to that lower rate code. So when you are putting someone who is an AOT member into diligent search, if you follow this, you're just going to document everything when you fill out your HML, even if you did not have that in-person face-to-face, but you did these various search efforts weekly, then you will just document that and then you'll note on your HML that you did have those contacts. Does anybody have any questions on that? Because this is a change to how we did diligent search for our AOT folks before. Okay, you can go to the next slide. Next, we have eligibility and appropriateness criteria policy. This is an annual update, but we did have some changes to it. We did add a statement in this policy just clarifying that prior to billing your first health home claim for your newly enrolled member, you must have your supporting documentation uploaded into the record. And that documentation must have a date on it. So we know that when that documentation was pulled, it was prior to that first claim. We have learned through our OMIG audit that we are going through right now is that they are looking to ensure that at the time that that billable claim was completed, that care manager knew that that member was eligible and appropriate for health home, and they would cross-reference that to the date that the documentation was uploaded and the date on that documentation. So that has been clarified in a statement in policy. The other thing that we really wanted to clarify is that if you have youth that you're enrolling, so you have somebody in outreach, you go to do an intake with them, and there is a chance that that member could meet HCBS level of care criteria, so the HCBS waiver for our kiddos. If they would meet or potentially meet that HCBS level of care criteria, just like you would talk about all other services that could be potentially available to that member, you also want to have the conversation about HCBS. And you want to make sure that that's documented. So anytime we're looking for potentially a higher level of care, if you are referring for CFTSS, if you're going to be referring for HBCI, if you have any of those other services you're offering, you want to make sure that you're documenting that. You want to make sure that you're doing the same thing with HCBS. Kiddos, the state, when they audit us next month, they're going to be looking for in our records, did we recognize when a youth needed a higher level of care or a higher level of intervention? And what did we do? And did we have that conversation with our members? The other thing that was clarified in here is that you will now have yearly appropriateness criteria. Every 365 days, you have to do the children's eligibility screening tool. That is not new. We have been doing that all along, that you had to complete that every 365 days. What is new is going to be the billing block for that not completed. So every single year, you want to make sure that you're completing an updated eligibility and appropriateness criteria screening on your kiddos, and that will transfer up to MAP. So if you fail to do that on time, you will have a billing block in place. We need to make sure that the kids that we're serving continue to be eligible and appropriate for the service. Any questions on those couple of things? Okay, you can go to the next slide. Also with this policy, we just put in a reminder that it is up to the care manager and or supervisor to maintain your sub-programs in NetSmart. So if you have someone moving into a program, you are ensuring that you're adding that program. If they discharge, let's say from HCBS, you're removing that HCBS program. We want to make sure that those sub-programs are up to date and accurate. The other thing that we have modified with this policy is that we've added a few new desk guides. We've added an initial appropriateness desk guide for adults and children, a yearly appropriateness desk guide for children, and a CES tool crosswalk for our adults. So below is just a few screenshots. So for the initial and yearly appropriateness, what it will look like, it'll be the appropriateness code, the appropriate criteria as prescribed by the Department of Health, what program it belongs to. So is it for adults, kids, or both? And then the supporting documentation that could be on file. So here you can see appropriateness code 10. That is for both adults and children. And it could potentially be that you have an adverse risk event because they have an H code or they have a K code. So that means that they're HARP enrolled for adults. And for our kiddos, those K codes mean that they're HCBS, have an HCBS level of care. So those two things, we would look to correlate. One of the places we would look to make sure that you're documenting the appropriateness would be, do you have that sub-program in there? Is that HARP sub-program in there? Is that Children's HCBS sub-program in there? That desk guide will walk you through the code, what the criteria is, who it's applicable to, and then where we will look for that appropriateness in the member's record. And that is for the initial for adults and children and for the children yearly. They're two desk guides, but they have the same format. Secondly, the CES tool. So what we have is members who are being assessed at the 12-month mark and then every 6 months thereafter through that continued eligibility screening tool for our adult folks. What you're doing is you're picking one significant factor or you're moving down to other factors that may keep them in the program. So if you're selecting whatever your significant factor is or your other factors, what documentation are we looking for to support that member continuing to be enrolled in Health Home? Again, you want to make sure that the CES tool is intended to make sure that these folks are still eligible and appropriate and engaged in these services in order to continue with Health Home. So if you do select on you're filling out your CES tool and you select, oh, they have a current quality flag in psyches, or they have a significant from a managed care company. So like a flag, a gap in care, an open gap in care. So what are we looking for? That is the reason that you have chosen to keep them enrolled in Health Home, because they still need to work on that. So what we should see is that specific QI flag from psyches or that open gap in care, we should see that either being addressed in the gap in care trigger or added to your plan of care or addressed somewhere. Ideally, it would be added to the plan of care. You can't just say, oh, yes, this person has this QI flag in psyches. Let's say it's not adherence to antipsychotic medications. That's the psyches flag that we're using to keep this person enrolled. then that care manager carry on doing care management, but never address the flag that has kept them in the program. So you want those things to kind of correlate. So this desk guide will walk you through those factors and what documentation or where in the record you would kind of support that member's continued enrollment. Does anyone have any questions on that? Okay, we can go to the next slide. All right, next we had an updated policy for our health home serving children, CS transfer policy. So those children youth evaluation services that Maximus through the Department of Health, they are the folks that do our non-Medicaid level of care for HCBS youth. There were some modifications by the Department of Health, and so we needed to update our policy. They added a statement that clarified that the receiving CMA, so the health home care manager, health home care management agency supervisor, they are the responsible party when they receive an HCBS use referral from CS. So I know that I have stressed this time and time again. Now they have put it in writing that yes, you were the ultimate responsible party. If you accept a referral for a youth that has active K codes and has an HCBS active level of care, you are now the responsible party to make sure that you have all of the required documentation. So the best way to do that is as soon as you get a referral, as soon as you see a K code, you immediately alert me. I will go in and I will double check to make sure that you have everything that you need before you accept that referral. Once you accept that referral and you were tied to that member with that A code, so you'll see the A code and E-PACES, you are now the responsible party. So they have put this in writing. It's something that they had been sending. And the second thing that they wanted to point out is CS is responsible for sending all of that required and relevant information. So if we get a referral from CS and it's routed through the health home, I always reach back out to CS. If I am missing something or I have a question about something, I will reach out on your behalf before I even kind of connect with you to finalize that transfer. I may say, hey, do you have capacity to accept this kiddo? But I'm waiting on the documentation just so I know that I have somewhere to send this youth. That's why it's super important that all of these referrals flow through the health home for this purpose. Something that we'll be touching on later is that this process will be changing slightly, but I will go over that when we do children's programs updates. So does anybody have any questions on this policy as it stands today? All right, I'm going to go to the next slide.
Can I ask a question about the previous slide?
Sure.
Actually,
Go ahead.
thank you. So my question is, going back to the CES tool and the quality flag, I often see in psyches mental health placement considered as a flag in psyches. And I was wondering if anybody could give me any kind of insight into what exactly that means and how that could be addressed for a client.
You know, that is a newer flag in the, I'm going to be 100% transparent. They absolutely discussed that. And I do not recall what they said, but I will look that up and get back to you because they did talk to us about it. I actually do not think it's an actionable flag, if I recall, that we do anything about, but I will look that up for you and I will get back to you.
Okay, thank you.
You're welcome. I dropped the ball. They definitely talked about it, and I do not recall what they said. All right, you can go to the next slide. You can actually go down to 11. Okay, so the next one we have is Health Home Serving Children, HCBS waiver, disenrollment and discharge. This is for our kiddos that are enrolled in HCBS waiver. This was an annual review, no changes. The one thing that I do want to emphasize is if you have somebody who is discharging from HCBS, please let me know before you do the discharge. I want to make sure that all of the paperwork is in order and has been issued, and that we, the health home, notify the Department of Health that those K codes have to come down. You should not be emailing capacity management anymore to let them know about the removal of those codes. We do that on your behalf. We also want to make sure that all the documentation is in order before those codes are ended, and then we can't do anything about it. So with everything with HCBS, there is a very, very strict timeline, and everything has to be done in order. So please notify the health home as soon as you have somebody that will be discharging from HCBS. Any questions on that? All righty, you can go to the next one. Next, we have our interpreter services policy. There is no update. It was an annual review, no changes to policy. The one thing that I did update was there was a slight tweak in the desk guide. Just when you called the number, the prompts have changed. So that desk guide has changed. So if you are utilizing the service and you have the old desk guide printed out, please update it. Just there was a slight change to the prompts that you pressed when you called that number. Does anyone have any questions on that? Alrighty, next. We're almost done. Next is our palliative care counseling and support services. This is for our kiddos who are enrolled in HCBS waiver. This is an annual review. There is no changes to this policy. The one thing that I do want to stress is that if this is a service that you are going to utilize, it needs to be in the approved HCBS plan of care in order to bill for these services. So these are very specific services that can be billed after member death, but they have to exist in that plan of care prior to that happening. So if you are going to be utilizing these services, please make sure it is an updated and approved plan of care first. Any questions on that? All right, next. And finally, our last policy is our systems access. There was an annual review, no changes. Continue to send in your activation forms and your deactivation forms. So if you need to add somebody and remove somebody, please make sure you are sending those into the health home, and we can either give and or remove access as needed. Does anyone have any questions on that? All righty. I'm going to pass it off to Travis, I think.
All right, thanks, Jessica. A whole boatload of policies. It seems like October is a heavy policy month. Actually, it is a heavy policy month. So thank you for bearing with us as the boatload of policies came through. Plan of care, adults and children. So Department of Health reached out to our health home, and they did it to a number of other health homes that use the NetSmart Care Manager product to talk about plan of care. And it was around the manual plan of care. So plan of care is that you print off and take with you out into the field to get signatures and dates. So what ultimately happened, Department of Health brought to our attention when they were doing a review with another lead health home out in the field. They had come across some concern about plan of cares that were manually out of compliance with the grossly out of compliance in some instances, with signature dates not aligning to the finalized signature date electronically in Care Manager. So the dates were really out of date, not matching up, or in some instances weren't even there on the manual document, when the Care Manager electronic date would be one thing, and there wouldn't be a date on the manual document, or the date would be so far different that it was a big compliance concern. So that was very concerning to the Department of Health, which prompted them to start reaching out to other lead health homes to start talking about this concern that they had. So they met with us, and part of that journey, and they started to talk to us about our process, and wanted us to take a look at as we move forward to tighten the belt on that area. So in doing so, we're asking as you move forward to make sure that you do not finalize the electronic version of the plan of care in NetSmart until you've uploaded, in the instances that you have a manual document that you printed off and draft, until you've uploaded it with a signature and date. Then you go ahead and finalize. And we want to make sure that it's within that 56 calendar days per policy, so that we can make sure that those dates align. Understanding that there are a lot of challenges out there, but for DOH to be in compliance to policy, we got to make sure that we're trying to make those efforts to be in compliance. If there's instances where there's already plans of care out there that have been finalized electronically and you've got signatures manually that you're trying to get out, we want to make sure that we're obtaining those as quick as possible and that we're documenting our efforts in Care Manager diligently, and that you've got the signature date that will be the date that you actually get the signature. We're not backdating, and that we're doing that as soon as possible. And then the other thing that we're asking is that if organizations, if supervisors could take a look at doing an audit internally of your plans of care, of those manual documents that have been uploaded, to see where you're at with your signatures and correspondence to what's not been signed off and dated versus what's happened, just to see where you're at internally. We're going to be doing an audit as a lead just to see where we're at as a network, because we want to see from a compliance perspective. Department of Health is going to be putting together some notes from their meeting with us for us as a lead for what they want us to do as next steps. We haven't gotten that guidance from them yet, but they will be putting something together from their meeting with us. But again, they didn't audit us at this point, but they met with us, brought forward their concern based on their review that they had with another health home, and they're meeting with all the other health homes that have the NetSmart product because of this concern they came across. So we're trying to be proactive in the steps that we're going to take moving forward. Another thing we're going to do separately is we've met with NetSmart, and we're having a meeting with NetSmart and the other health homes that use the NetSmart product in the region, in the state, and it's on November 6th, to talk about a product in the system to come up with how we can come up with a way to use the manual signature date and finalize signature date with the manual signature in the system to tighten up that loophole, to get that to be better utilized, so it's more functioning in the system. So that meeting's happening on November 6th, and NetSmart's already taken steps internally to try and work out that within the system before we meet as lead health homes with them. So that's another action item that's occurring. So I'm going to pause there. I've said a lot in a short time here, but I just wanted to give folks a chance to comment, respond, ask questions.
So Travis, when we take a plan of care with us out into the field to get it signed, then it would be in draft?
Yes.
and then we obtain the signature, and then we upload it still as a draft plan of care?
So you're gonna get your signature and date, it'll be uploaded as a draft. And then you get into your finalizing of the document.
But there would be no signature, correct, on the finalized one?
Can we even print a draft?
I don't know. I gotta admit, I'm guilty of one of those to finalize the first.
That was a question I put in the chat too, is that I have
Yeah.
not been able to print if it's in draft, nor can, for example, I cannot put like their names, you know, the client's name and my name in the sections that need it either without putting it in final status.
Yeah, I'll jump in here if you don't mind, Travis.
Sure.
Yes, that is all accurate information. When we met with the Department of Health, I was very clear when I talked to them that this was a temporary solution, that if we had to collect manual signature, that we were not collecting a manual signature on a full and complete finalized plan of care, and they were aware and they knew that. They said that they would rather have the signature ahead of time on a non-complete plan of care than have a late signature on a fully finalized plan of care. So in the meantime, just if you have to collect a manual signature moving forward, obviously an electronic signature is going to be ideal. I did explain to them, given the remote areas that we work in, it is very, very difficult. Moving forward, do your plan of care, leave it in draft, print it out, even as crummy of a version as it is. We fully understand that. Have that signed, come back, then finalize it. We have a meeting with NetSmart users next week to have our system modified. So we will have a better, I don't want to say workaround because it'll be a finalized process. We will have a better process for ensuring that we collect signature on time that matches the finalized date in the system. A couple people with their hands came up. Michelle, do you want to go?
The only other thing I'll mention, Jess, before we
Oh.
start answering more questions, is document everything along the way in NetSmart as you're going along, just for transparency. I'm really big on the transparency with the documentation, because we want to make sure that, you know, we're giving you this direction, but also documenting a record along the way, just for the full transparency.
Sure, yep,
Yep.
thank you.
Yes.
I was just going to add that sitting through other health home meetings about this, the same message. The biggest piece is that if we are printing off that draft, it has to be uploaded the same day. So that signature has to be in the system the same day that we finalize the plan. So if we're out at 10 o'clock this morning, and got a signature, a wet signature on a draft plan of care today, that needs to be uploaded in the chart and finalized in the chart, not tomorrow, but today. So those dates are consistent.
Hi, Michelle. Yes, thank you for adding that. This is where we are going to differ slightly. I do not expect any care manager, especially our children's care managers who work later into the afternoons because they cannot see kids till after school, for you to come home and be finalizing the plan of care. It can wait a day. What is going to be the best workflow is, in the interim, that plan of care, that draft plan of care, has a date, let's say a signature date of 10/28 on it, because I went out, I had my visit today, say I didn't get home till 6, 7 o'clock. It is okay for me to upload that tomorrow and
Mhm.
finalize the plan of care. So now that new finalized date goes to MAP. It's okay that the signature date is a day before that finalized date. What we can't have is it being finalized and then signature dates are happening well after the date that that plan was finalized. So it's
Yeah.
okay if it's a few days, especially if it's a few days before.
That's after
Yeah.
the fact, that's the issue.
Right. I think it's just, and I can say with certainty how much we appreciate your support with this, because you understand like living where we live and supporting our clients where they live so much of the time, like north of um Lake Luzerne, and that's even questionable. We are out of service, so it doesn't matter, where we're at. Sometimes there's just no service to get a wet signature. So we appreciate your support with letting them know, because in Albany they don't understand.
Yeah, I
They have
was
service all the
very,
time. We
very
don't.
transparent with the
Yeah.
state that nearly 75% of our plans of care are signed wet ink because we cannot just gather an electronic signature. It is not that easy for us. So I was very clear with them that this is a challenge that we will have to work through.
And I
Thank
think
you for that.
as long as we're showing reasonable due diligence in our effort and we're not, tardy in our response, we just need to be showing reasonable effort and being proactive and document in a timely response. That is, I think, showing the initiative behind it and not going days after the fact. To Jessica's point, if you're the next morning and it's before, there's not going to be an issue there from our respect, and we're going to advocate strongly for you as a provider and behind you. Now, if it was 2 days after the fact, that's an issue, right? So that's where we would have a harder time to support, because now we're behind the eight ball on that one. We're not proactive, we're reactive in that situation. So I think it's a situation where we need to, what's reasonable, what's this, what's timely, and looking at it from the respect of doing our due diligence and being proactive in our response.
Travis, it's Sarah. I just wanted to, two things. Can someone confirm that you can actually print a plan that's in draft form? Because I didn't think that you could, so I don't know how we would leave it in draft, print it, bring it back, and then finalize it. And then my other, I guess, just statement, not that it means anything, is, if we were having this problem and they noticed that this was happening, instead of going to this extreme, I think it would be helpful to put a timeline around it, 5 business days, whatever. But if you're noticing large gaps, it seems like it would have been easier for us to, make an expectation that you lessen the gap, but to try to make everything have to be on the same day, this is yet one more huge burden for everybody.
Yes, Sarah,
Duly noted on the comment,
on
Sarah,
yes,
for sure.
those are comments. I referenced the plan of care policy by the state. Ours is based off of that. And there is no time frame around that signature. It just says that it has to be signed. So yes, that is correct. We're fully aware. I run an internal team here. It is not easy. To do a lot of this work and a lot of the work in person, especially if you work on the adult side, there isn't that face-to-face requirement every single month with our members, so that makes it difficult. But yes, you can print a draft plan of care. It does not look pretty, but you can print it. Kia, do you
Okay.
still have a question?
Yeah, I do. You answered that you confirmed that we can print it. And then my other
Yes.
part of that is this going to be an issue with compliance? Because this is a draft and it's not completed. We're having them sign something that's not completed, and then we finalize it after without a signature, where we could have added additional information. So I'm just from a legality and compliance standpoint,
No, the
just want to make sure that I'm
compliance.
following.
Yes, you're okay. And again, this is a temporary solution for us having them print a draft. This is until we work with other health homes. to get a solution in place. So right now, this is just temporary with them signing that that draft version. And the compliance vulnerability is not that they are signing a non-finalized complete plan of care. The vulnerability is that you were saying that the plan of care is complete and done, and then getting a signature well after.
Could we
Go ahead.
get a signature? Would it be okay for the signature and date that we sign the date to match the date that we did the plan of care?
The signature on the plan of care and then
'Cause
the date that you finalized it.
Oh, yeah. So say that I do a plan of care and I finalize it and I print it out, and that's usually when I sign my name and date it. But if the dates have to match, can we just match the dates to the date that the plan of care was completed?
It would have to be the member signature
Yes,
on
their
the plan
signature
of
and
care.
date. Yeah, their
Could
signature
they
and
date
date
it
would finalize it.
On that day though?
So
'Cause
that
it's the
would
day that
be,
we built the plan of care together.
The date
would
they
have-
sign and date
Yeah.
it is the date that it's finalized.
I understand what you're saying. So if you met
Okay.
with someone, let's say telephonically today on 10/28, and you updated their plan of care, they were in agreement, you had a whole conversation about it. You don't see them until Monday the 3rd. Is it okay for them to sign 10/28 because the exchange that developed that plan of care happened on the 28th? So is
Correct.
it okay to backdate? No. Unfortunately, we should not be backdating. But again, this is a temporary solution until we come up working with those other NetSmart users to come up with a better solution. We were also audited about a year ago for our adult program, and this did not come up once when we were audited for that program. So I'm unsure to the level of concern that they have with this other health home that they audited, because that's when this flag was raised. So I'm not sure the severity of the issue and how much we have to go back and correct moving forward.
Right. And they did a thorough review of our program last year when they went through it. So, but nonetheless, we have to go through this exercise because they brought it to our attention. So clearly, as does the other health homes that are part of the NetSmart product.
I too just want to say thank you for being the voice for our folks that are in those rural areas that are unfortunately left out of so many resources as it is. This is just going to be one more barrier for them. Thank you for being their voice.
Yeah, and just FYI, I did work at a previous health home, and that was pretty much common practice to finalize it and go out and get the signature. Yeah, but just FYI.
Yeah, I think this is something that's happened and been happening, and it, you know, at this point, it's an issue and it's being addressed at the state level, and now it's being brought to the forefront, and we're all looking at it and adjusting policy. That's what's happening now. So
I do have a question. If these care plans are left in draft and they're past the 56 days because we just cannot connect with a patient to finalize it, if we're documenting in our notes that we're attempting to do this, will that satisfy things, or are we just going to be out of adherence until like forever?
I think, Karen, I think all we can do is document our efforts at this point, because we can't backdate, we can't make up documentation that we can't do something that if we can't get the proper information from the person, if you can't get in touch with them to do it, all we can do is document our efforts in that instance. So I would say that's the only other option you have.
As far as billing goes, though, no, you will not be able to bill.
Any other questions, comments around this? As we have more information, we'll clearly bring it forward. To Sarah's point, clearly a timeline would have been better for this. This is extremely inconvenient. We thoroughly understand that, and we feel it as Jessica had mentioned as well, as having an internal CMA as part of this network. We're feeling the pains as well. So duly noted. We'll keep everybody posted.
May I just ask, did they give a hint as to what their solution might look like moving forward?
As far as solution,
Yeah, you mentioned that they were going to look at the process and come up with something that would satisfy this. Did they make any mention as to what that could look like?
well, they were going to be coming up with like next steps for Health Home as far as action steps for us based on discussion we had with them. We're not sure what they are going to be yet, and it may be as far as like what they want us to do as far as looking at our compliance process based on our discussion with them. Maybe how far they want us to go back looking at our network as far as plans of care review, that sort of thing. As far as working with NetSmart, but we've already got to jump on regionally with the other health homes having a meeting with NetSmart. That's already been scheduled, so that's kind of a step that's already happening. So that's an action item that's kind of already in motion. Think those are the types of things that they're looking to see happen to close the gap on this type of thing from continuing. And I'm not sure what other types of things they may come up with as far as recommendations for this to prevent this type of thing from occurring moving forward. But they don't want to have a gap from the electronic signature to a manual plan date finalized happening moving forward, period. They want the same signature dates aligning within the 56 days.
Okay, thank you.
Yep. Any other questions?
This is, I know we're talking about the initial care plan of cares. Is this also going to be for amendments as well?
I think it's gonna be any care plan. So anything that's any update that's gonna require signatures, that's gonna get uploaded to MAP. Anytime there's an amendment, that's gonna get signed and uploaded to MAP. You have your annual upload, your initial, that's gonna get uploaded, then you have anytime something that's amended, that's gonna be tied and uploaded. It's gotta be signed and dated. Looks like Mary's got a question.
Sign it by the end of the month.
Hi, Travis. Well, it's not a quick question if it with this subject. So we have let's just talk about an amendment instead of initial plan. So if we have an amendment due, we leave it in draft. For whatever reason, we can't get the signature, right? And until we do, it stays in draft. It doesn't go to final. I think it's the same question somebody else asked about the billing block, because plans are due every 365 days. So for example, if it was due on the 22nd of October, we still don't have it done. We don't have it finalized by the 31st because for whatever reason, I don't know, maybe the person's incarcerated. Maybe they're in detox or something, MHU. Is that going to cause a billing block? Because it's not going to, that finalized plan's not going to pull over to show that it was done within 365 days of the previous one?
If they're pended because of they're in an excluded setting, Jessica.
Not pended because it hasn't been 30 days. Hasn't been, I've just used that for an example. So you can't find them. Let's just use can't find them. I don't know, maybe went on a trip somewhere to see somebody for a few days, but they keep canceling whatever. Because it's in draft, it's not finalized. So therefore you do not have a plan on file within 365 days. Is that so that it's not going to pull over to map in a draft. So are you then going to lose billing unless you provided a core service prior to that plan being due? You know what I'm saying?
I guess I'm not following you fully, no, Mary.
Mary, I'll take this one. No, you would not be able to bill. There would be a billing block.
Correct, because right now, if a plan of care, an amendment is due on the 22nd of October, we don't do it on the 22nd of October. We were late. I don't know. The care manager got the flu, whatever happened. If we provided a core service prior to that plan, right, being due, we can bill. But let's say it wasn't due between the 22nd, it wasn't done between the 22nd and the 30th. I'm making that up, and we didn't provide any core service prior to that 22nd. Right, it's not going to pull over, so there's going to be a billing issue.
Okay.
Yeah, I think Jessica, you understand where I'm going with it, right? Because there's a lot to track with it. Okay.
Yes. So what will need to happen, and this is regardless of whatever a modification we make to our Not Smart plan of care, moving forward from the date that memo was sent out, this will be the workflow in order to be able to bill. You have to have within the first 56 days a finalized plan of care with a electronic signature or a wet ink signature. If it's an amendment, then you have to have it 365 days or less, finalized plan of care with a wet ink signature or an electronic signature on that plan of care before you can bill. So let's say your plan of care was due on October 20th. You did it with them on October 20th. Let's say it was due, you did everything, but you did not get the signature until today. You cannot bill for anything until today, which makes that last contact not billable because the plan of care was overdue. Does that make sense?
Yes, that's what I was getting at.
Okay, perfect.
Thank you.
Yep. So a plan of care is not billable until it is finalized in the system with a signature on it. Kia, do you have a question?
Yes. So I remember we talked about how the comp assessment can now be done like over the phone. Not all of that has to be in person. I'm just trying to find a workaround for this. Can we complete the plan of care or the assessment and plan of care and then go get it signed?
Yes.
I'm just trying to.
Yeah. So if you have,
I mean, can we do like over the phone, do the comp assessment over the phone?
As
right,
long
do
as
the
it's
plan of
not
care.
the initial comp
Okay.
assessment needs to have is some sort of affiliated face-to-face with it, but you would already kind of have that affiliated face-to-face because you did the intake.
Yeah.
And I believe it's most everyone's process where you may not finalize the comp that day, but you gather a lot of that documentation.
So would it be okay if I did the comp assessment over the phone with them, did the plan of care, and then met with them to have them sign the plan of care?
Yes, as long as the plan of care though still was in.
Still, the only reason I say that is because sometimes getting them to engage like getting them is sometimes the issue. So if I get them on the phone,
100%,
yeah. So that's why I'm trying to find a workaround to get the comp assessment done over the phone and then schedule time to meet with them to sign that draft plan of care, to come back to the office and finalize it. Then that will work.
That
Just
will work, but
only
if it's
the-
If
The
it's the
initial,
amended.
the initial, you would have to have one face-to-face for the comp assessment.
Okay.
At some point.
Okay.
Other than that, you're all right.
Phew, okay.
These are all really good questions. Any other questions? Okay, well, we'll keep you posted as we get more information. Thank you for all the questions and conversation around this. Another popular discussion, DataDen. So NetSmart changed servers. They had a server that was called Oracle. And they changed over at the beginning of October to what was called Post GRESQL. And then as of the weekend going into the 17th, it was going to be fully transitioned over into this new server. And that was the last time that there was actually a full refresh of data for DataDen. And since then, we haven't been able to do a full refresh. The new term for the server is called Redshift. And we're having a hard time having the data tables align in this Redshift server platform. So we can link to it, the Power BI platform, which is DataDen, Power BI DataDen, but we can't get those data tables to align like they did in the old server, the Oracle server. So we have to kind of rebuild those data tables to link to each other in the back end. So that's what our data analysts at AHI and some other folks are trying to do and working with NetSmart to try and make sense and get that stuff to link up. So that's why you haven't been able to get good quality updated data in some time now. So we greatly apologize for that. We're trying to get it connected as soon as possible. We can, again, get connected to it on the back end. It's there, but it's getting it to get the tables to connect fully so that you can see those Visios, so the data can flow to get those reports like you're used to, which you will get. It's going to happen. It's just a matter of getting it built again to a point so that it's flowing. So it's in process. We're working to get it together as soon as possible. We're hoping sooner than later. So please bear with us as we're getting that stuff back together. But there's not going to be quality notebooks this month around, unfortunately, because of this project issue that we're facing. But that's the status of DataDen. But you can go in through October 17th and pull reports, have data up to that point. As far as billing refresh data, Taylor, was that current up to that point as well? I
No,
can't, no, that's not, okay. I can't remember when the last time that one was current. I'd have to go back and check on that. But that's the status of data then currently. But we have we're meeting once or twice a week internally trying to figure out what's going on with that, and we've got an analyst working on it throughout the week, trying to put those tables together, connecting. So that's data then currently. So again, our apologies. We'll keep pushing on it, get that back together for you guys. Redesignation, next Monday, we have the entrance meeting. This past Monday, it went out to every CMA supervisor. It was only supposed to go out to all the children's supervisors. We sent out the list of our CMA contacts and highlighted only the children's CMA supervisors, but they sent it to every one of the CMA supervisors. So some of you may have gotten an invite to complete the children's redesignation survey, and you shouldn't have. But the survey went out to all the supervisors, and as a chance for those children's supervisors to fill out on behalf of the lead, to give feedback about how we're doing for quality and performance. And that information will be shared with the lead staff during our exit conference at the end of the month in November. They're going to be meeting with us next Monday. Basically, we'll be giving them a walkthrough of NetSmart so that they can go on and start doing the chart audits throughout the month for the SINs that they have pulled. And we submitted our entrance packet for all of our stuff we had to do in preparation for the audit on the 18th and the 20th of October, and gave them everything in the kitchen sink, basically, of what they wanted and more. So now we wait and see how everything kicks and comes back. And we'll keep you up to speed as things unfold. So that's redesignation thus far. And I'll kick it over to Jessica now for a couple more children's updates.
Hello, just some two quick updates. I alluded to this earlier. There is going to be a process change with CS, and that CS transfer policy, because the contract with CS is ending for March. So you guys, as you've known over the past couple of months, you've seen the switch over that SPOA can complete those level of cares for HCBS youth with Medicaid. Again, if you get any of those, please make sure it comes to me so I can check it. The other thing is that non-Medicaid youth population, so all of those kiddos that didn't have active Medicaid, they were going to CS for that evaluation of level of care. There is forthcoming from the DOH no plan in place. We are not sure what we are going to do. They had initially proposed that it was something the lead health homes could take on, but that goes against CMS rules. So stay tuned for updates for our non-med youth and what the process will be with them for HCBS eligibility. Secondly, the long-coming HCBS training in the UAS will be live in November. So this is going to be the level of care certification that you will need when working with an HCBS youth. So if you are going to be completing an HCBS level of care on any of your kiddos, you will have to have this certification. It will go live in November, but there is no defined deadline yet, saying if you do not complete it by X, you will not be able to do your LOC. It will go live in November. They're thinking they'll give you through Q1 of 2026 before they then shut off your access to do those level of care. So over the next few months, as soon as it goes live, if you have time to kind of walk through that certification, please do so before you get that turned off in the UAS. Does anyone have questions on either of these items? Alrighty, go to the next slide. Upcoming trainings, we have scheduled Thursday the 30th at 1 p.m. It's a health home serving adults overview. So it is an extremely condensed version of our adult onboarding. So if you have any new adult care management staff, you would like to come to that, it's going to be Thursday at 1. I believe it's going to be myself and Taylor. On Monday, November 10th at 9:30 a.m., we have the health home serving children overview. So again, an extremely condensed slide deck for an onboarding for a children's staff. So if you have any new children's care managers, you can send them to that. And then in our next micro training series is going to be health home serving children's assessment. So we will going over all things children's assessments related on November 13th at 10:30.
Thanks, Jessica. Health home workforce survey, just sending out a reminder. I sent out earlier today again. Lori Lamphere from New York Health Home Coalition sent out a reminder. Just we're coming up on about a week, a little bit over a week left on the open survey. So if you haven't had a chance to fill it out yet, feel free to do so. I got a couple people reach out saying that the link wasn't active when I forwarded it, so I'll resend it after today again. See if I'll check to make sure the link's working. It looked like our particular health home region had 29 responses so far, so you know, we have an opportunity to get some more in there. So folks, it's our chance to get our thoughts on how we can improve health home services and get some input in there. And this does get back to the Department of Health and can help potentially shape some policy and input to policy. So, you know, please, if you have your thoughts and beliefs on what you think might be able to help change and make change, here's an opportunity to get those thoughts in there. So I think November 3rd, yep, it's on the bottom. November 3rd is the deadline. Each year there is usually an extension, so that might be a possibility again if there's a chance to get more in there. So that's coming up. And then the next thing is there's a Social Care Network regional networking event for the North Country. It's Wednesday, November 19th, 8:30 to 12:30 at the Olympic Conference Center in Lake Placid. There's a registration link. I did send this out prior. I can forward that as well again for those who may be interested. It's a regional convening just to get to know networking, get to know different vendors, providers, get to know more about your social care network, regional reps, etc. And that's happening on the 19th of November in Lake Placid. So I'll send that forward as well for those that may have an interest. And that is what we have for this meeting. I didn't know if anybody had anything else they wanted to talk about or anything they wanted to comment on. If not, I want to thank everybody again for everything you do each and every day, and I hope you all have a good rest of your week and have a good Halloween for those of you who are going to celebrate Halloween.
Thank you. You too.
Thanks, everyone.
you.
Take care.
Thank you.